Welcome to AETCM, the Emergency Medicine channel. Today we're discussing about a 58-year-old female who came to a year with complaints of a lower limb pain. She'll begin, sir. So, a 58-year-old female was brought to here with complaints of right lower limb severe pain and some discoloration since past 2 days. Because of severe pain, actually, she was not able to go to the OPD or anything, so she directly came to our ER. So we received in a trolley. On initial testing assessment, she was conscious, oriented, and obeying to my commands. In the primary survey, her initial primary survey everything was within normal limits only. Airway was patent. There was no signs of any obstruction. Breathing, she had a respiratory rate of around 18 per minute. SpO2 was maintained 98% in room air. Circulatory part, her pulse rate was 87 per minute, and blood pressure record was 126/70. Disability, she had a full score of GCS, and exposure part, she was febrile. There was no history of any fever or anything, and she complained of a pain score of 7/10. At this point, we initially offered her a 1 gram paracetamol IV, and followed by that, we also had to give her a 50 milligram of Traumatrol because of severe pain. So both were actually given back to back because of severe pain, and we continued our survey.
Tramadol, how do you give Tramadol? What are the adverse effects of Tramadol?
Traumatrol actually is a opioid drug, so actually we usually give in like a moderate to severe pain indicated. We usually dilute it in 100 ml NS and give over a period of like 20 to 30 minutes.
Antiemetic?
Antiemetic should also be given before giving Tramadol, and also we have to rule out any history of seizure episodes in the past because it can reduce the threshold of seizures. So this patient actually doesn't have any history like that, so we give in after paracetamol.
What is the clinical finding of Traumatrol withdrawal? You might have seen Traumatrol withdrawal cases. Tramadol can be abused. Okay, it's one of the common drug abuser.
Thing will be the patient may not be satisfied with any other drugs like lower drugs like paracetamol.
Seizure. Patient coming with intractable seizure is one of the major findings seen in Tramadol withdrawal. Patient who is taking Tramadol as a recreational drug for a longer period, they can present with the seizures, intractable seizures.
So in our primary survey here, ABC's everything was within normal limits only. She had the only issues with the pain, so we started on Traumatrol infusion, and then we continued our secondary survey. Adjuncts, there was we only took a ECG to, it was showing only sinus rhythm of about 90 beats per minute. There was no other abnormalities, and GRBS check was 121 milligram per deciliter. So secondary survey, the patient complained of bilateral lower limb pain she had since past two years, but intermittently actually it relieved on rest, and intermittently it worsened on walking, like claudication pain. But actually since the past 2 days, this pain has acutely increased over the right lower foot with some bluish discoloration at the tip of the all 5 toes. But there was no history of any recent trauma or any history of fever or any local infection like features or any ulcer or any discharge. For this complaint, actually initially she was taken to a nearby hospital, and there actually they gave some pain medications, and since it was not relieving, they did an imaging. She underwent a contrast enhanced angiography. It was showing absent flow to the right dorsalis pedis artery, posterior tibial and anterior tibial artery on the right foot, with showing features of complete occlusion, but there was no features of any thrombi in the scan.
Normally, when you examine a case in emergency room with absent pulses in one of the limb or one or two limbs, what are the differential diagnoses you suspect?
So first we'll have to rule out an acute limb ischemia, so because that's an emergency. Patient presents with acute onset of pain with parallel being there and cold extremity, cold to touch in comparison relatively to the other extremity. And absent pulses has to clinch a diagnosis of acute limb ischemia, and that has to be ruled out. Then apart from this, in old people, even atherosclerotic veins also, it will be harder, especially the dorsalis pedis artery can be harder to palpate. And vasculitis can be a reason causing, without a thrombus, patient can
You say female patient. Middle-aged female. What are the common things? Vasculitis is a general diagnosis.
One thing be like one could be like an acute limb ischemia due to some reason, like an acute thrombi or something. Then hypercholesterolemia.
Hypercholesterolemia is cause for the thrombus.
For thrombus.
So the one thing is mainly thrombus. Second thing is
then some vasculitis.
What vasculitis? Aorta arteritis. Aorta arteritis is one of the major cause for disparity in pulses and high BP in some limbs. Okay. Then any type of medium vessel vasculitis, not large vessel vasculitis. Large vessel vasculitis normally present bilateral loss of the pulses. Here only one limb is
affected.
so medium vessels are affected. Okay, it's all vasculitis only. It's all arthritis or vasculitis. Okay, whether it is aorta arthritis or anka panka related arthritis. So many arthritis can be there. We have to see what it is by doing lab investigation.
So suppose we are getting a patient like with like a unilateral suspecting limb ischemia, we have some clinical features which can be like classical. We can think about that we call it like classical 6 P's. The first one will be pain. Significant pain will be there. Mainly, usually, will be like more rest pain will be there. And if it's like a more like a viable limb, the patient may also complain of claudication pain. As the patient keeps walking, the pain can increase.
What is the difference between claudication pain due to arteries and claudication pain due to nerves, neuroclaudication symptom? Both are different. Both will have lower limb pain.
Sir, in claudication because of artery blockage, in that the patient will be able to walk for a while and then he takes rest and then he'll be able to walk.
So pain increases on exertion, relieves on rest.
Release on rest.
But in neuropathic claudication pain will be persisting throughout.
Pain is there on standing and relieves on stooping forward. Mostly neuroclaudication is due to the spinal canal stenosis. So they get relief on stooping. Okay. Whatever it is, when they're standing itself, pain is there, it is neuroclaudication. When they're walking, they develop this one, it is arterial. Okay. Here it is arterial claudication.
So supposing considering the gradient of like ischemia, the patient can have different clinical features on the affected limb. So the most common will be pain. It can either be a claudication pain or along with the rest pain. Then the patient may have local pallor on examination, and also the patient may complain of paresthesia and numbness on local site, and also if the symptoms are worsening, he can even go for paralysis or motor involvement.
Pallor is described in books, but don't think that a patient we can see pallor. Pallor is a feature of spasm, not
like
not an ischemic limb. You don't see ischemic limb pallor at all. You see cyanosis, then tip cyanosis and gangrene. But whereas in spasm, you see pallor, then cyanosis, then on rewarming, you see the redness. Okay. So pallor, don't tell that pallor is a feature of ischemia, critical limb ischemia. You see generally blue limbs.
Then on if you try to feel the limb, it will be cold to touch, and also absent pulses.
Okay.
So that will be like the typical clinical features you can see in a suspecting acute ischemia patient.
Tenderness.
Tenderness. Okay. So this patient actually, with this complaint, she went to another hospital initially, and they found to have some arterial occlusion on the right lower limb, affecting dorsalis pedis, posterior tibial and anterior tibial artery. But there were no features of any thrombus noted in the scan. Since worsening pain, she was referred to our hospital. She doesn't have any her non-chromosomes. Actually, she's had a previous history of ITP in the past, but no other history as such. She's taking any medications or anything. And so, yeah. On arrival, actually, because of severe pain, we started this medication and we went to the clinical examination. So, on clinical examination, the left foot was somewhat appearing to be normal, but on the right side, there was bluish black discoloration on all toes. Up to the midfoot, we were able to see that bluish discoloration, and we were able to feel warmth up to the ankle, but beyond that, it was completely cold. And there was severe tenderness actually if you're trying to touch below the level of ankle. Severe tenderness was there. And also when we asked her sensation, she was not able to feel any sensation beyond the level of ankle. So absent sensation was there, but severe tenderness was there. And also bluish discoloration was extending from midfoot till to the toes. But there was no tenderness or swelling above the level of ankle. We tried to palpate this thing. Popliteal and femoral was palpable on both sides. And on the left side, all other pulses are also palpable.
Okay.
So it was more like an isolated right foot ischemia.
Okay. In emergency room, rather than palpating the pulse, you can use your ultrasound Doppler. That is better because many a times in aberrancy of arteries are aberrant. You may not get the pulse. So you cannot fully depend on the pulse only. But when you have clinical finding like this, absent pulse will tell you that there is ischemic limb.
So after our actually initial clinical examination, we also tried with our handheld Doppler also. It was also not showing any picking up on the right side.
Okay.
Mainly on the dorsalis pedis, posterior and anterior tibial artery. So this was our patient. So clinical features actually there was no history of any trauma or any other history which was a history of an acute injury to the artery or anything. The only history was she had a previous suspecting APLA syndrome in the past, for which actually a complete evaluation was not done, but some referral letters were showing like an APLA syndrome was there.
So what do you mean by APLA syndrome?
Basically, it is like antiphospholipid antibody in the
How do
circulation.
they present?
So the patient will be in a high prothrombotic state. So
No, how do they present? A female patient who is
Missed abortions will be there, sir. Yeah.
So you have to
Which is
ask
not
miscarriage, misabortions. It is very important. Okay, that history has to be there. But otherwise also APLA can occur, like thrombus, embolism, all these things can occur.
So this kind of a history actually they gave, but there was no diagnosed case or anything. So in view of persistent complaint, she was admitted for further evaluation. So considering there was no thrombi in the system, so her treatment plan was actually not like in a like a usual case of acute limb ischemia. So because the patient coming with acute limb ischemia, the most common issue will be like an acute thrombi. A thrombus occluding the artery below the level of the lesion, and so our priority will be to like remove the thrombi either through a procedure or through like a thrombectomy or like a thrombolysis. So that will have like an urgent plan of management in those kind of patients. But this patient only issue is actually there was no actual thrombi noted in the scan to like lyse or to like go for a surgical revascularization. So our plan of management was first is painkillers, then to increase the blood flow. We had some options. One was to actually we were suspecting vasculitis. We gave a bolus dose of steroids. We gave this thing dexamethasone was given, 8 mg was given, and following that, even though still patient was complaining of pain, we had to go for second line managements, which we usually go for refractory Raynaud phenomena and those kind of cases. Basically, so suspecting possibly a vasculitis or maybe some other like extra vascular occlusion, we started him on pain management. Vasodilatory medications like prostaglandin infusion was started, and also this thing, calcium channel block was also started. And with these 3 medications, she was admitted for further evaluation, but her pain was not resolving.
Okay.
So we clinically assess the patient like to grade the limb ischemia to consider for other options. So we have something called a Rutherford grading, in which we have like 3 classifications, which we can divide the patient as a viable or a threatened or a reversible injury. In that, the first one will be viable, in which the patient can have like audible arterial and venous pulses, in which the patient is not in a case of like in a state of acute emergency, so as which require intervention. But the second stage will be like a threatened state, which again have a 2-level classification, which is salvageable if promptly treated or salvageable with immediate reconstruction. So this patient was not in that group also because she was having a motor involvement. So basically, the patient is having absent venous Doppler and also absent arterial in the scan, along with some partial paralysis or sensory loss. The patient will come in threatened but salvageable with immediate reconstruction. But suppose is not having any motor involvement but some sensory involvement, the patient will come in threatened salvageable group type A. So basically viable threatened type A and B, and then the third will be irreversible. Irreversible means there will be motor, sensory and both arterial and venous involvement. So in this patient will come under irreversible type 3.
Okay.
When we started with a conservative management, at some point she will have to go for like an amputation or that kind of plan for further management. But suppose the patient was coming to our ER in the initial phase, the things which we could have done was mainly to start on high grade opioids like for pain relief, and then suppose in case of vasculitis, or we can give high dose steroids as a bolus.
If it is not due to diabetes, like diabetic atherosclerosis, we can definitely give steroids. Okay. Because high dose steroids, sometimes it can reverse the vasculitis. But if it is due to diabetes atherosclerosis, then we cannot do anything. Sometimes it can be diffuse atherosclerosis.
So suppose we are getting a patient like this, we have to think about all the causes which can cause acute limb ischemia. So the most common will be arterial thrombus, which can either be an acute occlusion or maybe in a case of already non-case of PVOD, been acute on chronic occlusion.
What are the conditions which can produce arterial thrombosis? Arterial thrombosis, not venous thrombosis.
Diabetic microangiopathy.
Diabetic angiopathy, that is a chronic arteritis can be produced. Is atherosclerotic arteritis. Diabetes, then dyslipidemia. Other than that,
any atherosclerotic plaque occluding.
It's the same thing. Atherosclerosis is only one type.
Then any thrombus of any already existing aneurysm.
Existing aneurysm.
When you arterial lines and all, when the lining of the artery is being
Trauma.
Okay.
Then any hypercoagulability state.
Which one?
Like APLA.
APLA.
Protein C, protein S.
No.
Any malignancy.
APLA is correct. Protein C, protein S and all normally produces DVT. APLA is one. Hyperhomocystinemia is two.
Any
Two important thing. Then malignancy induced thrombosis.
Then DIC and also.
DIC normally will not produce large vessels vasculitis. They produce very small vessel vasculitis. Okay. Multiple small thrombi you can see.
Then actually could be some arterial embolism due to some other cause. Like
From the heart.
From the heart.
Okay.
Secondary embolic and
Okay.
then could be some vasospasm.
Okay.
Or any like other causes.
Okay.
In that actually features as like conditions like Raynaud's phenomenon or something like that can also like present with similar conditions.
How do you manage Raynaud's phenomenon? Raynaud's phenomenon also patient will have severe pain, vasospasm. Initially it will be pale, then blue, then red. How do you manage that?
It is treated with antiplatelets and majorly by calcium channel
block.
Vasodilators. You can start NTG or calcium channel blockers and make the limb warm.
And we avoid any triggering factors.
Okay. Anxiety, fear. Okay.
So basically arterial ischemia, if you are taking this patient, it's more like in a clinical picture of more like a Raynaud's phenomenon. And in those conditions are supporting, like we are going for like a refractive management. There are multiple things we can do. One is to make the limb, that area warm and all that. Then pharmacological measures, we can go for IV prostaglandin infusion.
Okay.
And also calcium channel blockers can be given as orally. And if the patient is still not recovering or having more symptomatic, we can go for local or regional blocks. The affected area actually we can go for like regional blocks using lignocaine or a long-acting bupivacaine. Along with it, we can add steroids also, but without adrenaline we have to give. And this can actually
again produces vasospasm. That's why.
So local without adrenaline and also either lignocaine or bupivacaine can give us symptom related for about 12 to 44 hours. It's like short-acting temporary measures which we can give. And also the patient is even though not like any clinically proven benefit, but there are multiple other treatments also recommended, like botulinum toxin can be injected locally to relieve pain, and also oral prostaglandins can also be started.
Botulinum toxin also relieves the spasm. It relieves the spasm in muscles and arteries.
And also like in old times,
botulinum toxin is used in clinical medicine to relieve the spasm.
This thing
not in cosmetics.
Migraine.
This is used because migraine, some muscles are having spasm. That muscle spasm can be relieved by botulinum toxin.
And so if your initial conservative management is not working, then one of the old classic rule in this thing is treatment is digital sympathectomy.
Okay.
So we actually surgically go for sympathectomy of the affected area. This again is actually only for the subjective benefit of the patient, but it is not actually curing the disease. So later the patient most probably will go for like amputation. Or like they'll be like the end stage of the disease.
Okay.
So this is the management. Supposing considering this patient, there is a patient with acute limb ischemia without a thrombi, so probably secondary to a vasculitis or like an inflammatory process.
Mostly this is due to vasculitis. APLA syndrome diagnosis was done previously. So there is a most common cause for critical limb ischemia in a female patient like this. Okay.
So the things so if we take in the total whole picture, we have to first diagnose the patient. First clinical things we have to look for, the classical 6Ps or like the features we have to think about, and then suppose there is an absent pulse, we can, whatever is available as quick as possible, we have to go for. Whether it's an arterial Doppler or even like an contrast enhanced angiogram which we can give a definite diagnosis. Suppose it is actually a thrombi occluding the causing the ischemia, we have to go for either surgical or a mechanical thrombectomy, or we have to go for thrombolysis. Thrombolysis again we have like streptokinase or RTP or urokinase can be used for intra-arterial thrombolysis, which is the treatment of choice mainly for acute thrombal obstruction. And suppose the patient is not having an obvious thrombi in the system, we have to think about other causes, which can be like traumatic, iatrogenic, or maybe even like inflammatory or vasculitic conditions. So this conditions, the treatment plan will be completely different because there is actually no actual role for anticoagulation or any those kind of treatment plan because it is not going to give a much benefit. So our aim will be to like go for symptomatic management and also to give drugs which can actually dilate the vessels can and also improve the circulation. So we can go for like high grade high level analgesia. Then second will be dilatory medications like prostaglandin infusion, then calcium channel blockers. Then if required, steroids can also be given. And if it's not improving, then we go for a local infiltration with a local anesthesia to relieve the sympathetic supply.
Okay.
And finally, sympathectomy and then amputation will be the plan of management. And also, these patients there is a high risk for again thrombotic occlusion. So we have to start for antiplatelet like aspirin can also be added, and also statins can also be added. So both to avoid thrombotic further events.
What are the infections which can produce vasculitis infections?
Endocarditis.
Endocarditis.
Infective endocarditis can cause the LV clots and again
There is embolism.
embolism.
Vasculitis.
Giant infection.
Tuberculosis,
TB, syphilis.
syphilis.
These are two important infections. Syphilis nowadays,
Iotitis.
it is less, but even then it can produce arthritis. TB also can produce peripheral vasculitis. So one of the common conditions you see is
India.
non-healing ulcers in the lower limb. So many patients it can be tuberculosis, either on the ulcer bed itself TB can be there, or sometimes vasculitis can produce TB. So vasculitis and TB has got a strong relationship. Even syphilis. Other conditions, so many other infections can present, but this is very common in India.
Okay. So this patient actually, even though we started on this clinical management, actually
Patient
didn't
never had any improvement.
so actually,
So what will be the ultimate plan for this
ultimate
patient?
plan will be for amputation.
Amputation. Otherwise, that will go to gangrene.
Gangrene.
What is wet gangrene and dry gangrene?
Wet gangrene means basically an acute infected gangrene. So we have to like.
So wet gangrene will be moist and it will not have any demarcation, and it will more often than not it will be because of any anaerobic like Clostridium perfringens that will cause a wet gangrene. Dry gangrene is merely lack of blood supply to that area causes that area to undergo
non-healing.
ischemia and necrotic.
So
and
dry
that will have
gangrene is
proper
mostly
demarcation.
because of the arterial occlusion, whereas other one can be an infection or venous occlusion. Anything can produce
It will have a proper demarcation.
demarcation. Okay. So this is a arterial occlusion. This will go for a dry gangrene if you don't treat, and auto amputation will occur. But if it goes for auto amputation, patient will have to will have a lot of pain, infections, lot of complications. So better to amputate this patient.
And also differential diagnosis we can think about is like in any compartment syndrome,
Okay.
or maybe even DVT can rarely cause this kind of symptoms. And also any a patient who was in chronically in multiple inotrops and all kind of local limb ischemia, but it will be like diffuse and all affecting both limbs. Unilateral is unlikely. And also any acute compressive neuropathy.
Okay. If you start peripheral lines, this what you told your vasoconstrictors like norepinephrine. Through peripheral line, sometimes you can see peripheral gangrenes. But nowadays we don't use noradrenaline through the peripheral line.
Usually
We
go for
use,
central line.
but peripheral settings it can happen.
The most important dealing is the compartment syndrome.
Compartment syndrome.
Again, another emergency.
Okay.
So in which the patient will be having excruciating pain without any not relating to the clinical thing. So that'll be our plan. So basically, the patient is coming to ER with complaints of acute lower limb pain or like severe pain. We have to always consider acute limb ischemia as the first DD, which we have to rule out. And in that, after clinical examination, even if I have suspicion, whichever this thing is available as early as possible, we have to utilize for diagnosing the lack of blood supply. So either we can go for a USG Doppler or something which we have easily available, or definitive management we will either go for an MRI or a CT angio, which can give an which can be useful for like further management also. There are also like techniques which we can use as an intra-arterial imaging. So suppose we are getting an obstruction, we can at the same using the same dye and system we can go for a lysis also. That is also preferable in settings available.
Okay.
And also these patients we have to go for, like we are admitting the patient, we have to rule out other causes like prothrombodic situations the patient may having, which we have to like treat along with the condition. So also the suppose the patient is coming on arrival, the clinical appearance can give some clue about the patient's clinical status. So suppose the affected limb is showing just pure white, it could be a sign of acute ischemia. But it is more like a pink or blue appearance, is more like a chronic ischemia with some acute exacerbation. And suppose the patient is having fixed mottling in multiple areas, is more sign of a poor prognosis even in the early appearance itself. And also again a dry gangrene is more like a too late stain. Most probably the patient will go for amputation. So these are the things actually we can look for even in the clinical initial appearance itself to like grade the patient. So and also one thing to notice, audible arterial Doppler cannot completely eliminate the sign of diagnosis of acute limb ischemia. So that also have to be like keep in mind. And also we have to like rule out any secondary embolic like episodes, and we have taken ECG to rule out any AF or other cardioembolic this thing also in this kind of patients. So considering our patient, she was basically a patient with acute limb ischemia without a thrombi, so more secondary due to vasculitis. So we initially managed the patient with analgesia and vasodilator medications like prostaglandin and calcium channel blockers, but with no improvement.
Steroids.
Steroid also was right, but not improvement. So now she's planned for like amputation as a plan of management.
Okay.
Okay.
Anything else? Okay. Thank you.
Thank you.